So our model at Virtua has really evolved over several years. We started with embedding a handful of licensed clinical social workers, physically embedding them within our primary care practices to provide therapy for our patients. We did that with a nurse practitioner, a psychiatric nurse practitioner, who was available for kind of support for those licensed clinical social workers when they needed it. That psychiatric nurse practitioner was also able to consult with our primary care physicians, regarding either diagnoses to make sure that they were making the right diagnosis of a patient, and then could also provide recommendations regarding therapy. What is the best course of action from a medication standpoint, and so that was very helpful. We were then able to expand the medical side of it to where we've now hired. We have three psychiatrists, three medical doctors, psychiatrists, who are embedded in the practices, along with that same psychiatric nurse practitioner, who are able to offer like a consult service for our primary care patients. So when our primary care physicians are faced with challenging cases in terms of behavioral health or mental health, they can refer patients to be seen by any of these three psychiatrists or the psychiatric nurse practitioner, who will then see the patient, evaluate the patient, can start them on medication, and then the goal is that they kind of stabilize the patient and then send the patient back to the primary care physician for ongoing management. So from a medical standpoint, those three psychiatrists and the nurse practitioner, they're there really for short-term support, a few visits, to kind of bridge the acute needs, to make the diagnosis, to get them started and stabilized on medication. But then the goal really is to have the primary care physician be able to then take over the reins and be able to continue to care for that patient. And a lot of that simply comes down to the practical issue of there's just not enough psychiatrists to go around. There's not enough psychiatric nurse practitioners to go around. So if the psychiatrist kind of took these patients on and just continued to see them forever, they would very quickly fill up and wouldn't be able to continue to provide this service for our primary care patients. So they're really there for short-term support, and then to get the patient stabilized and then back to their primary care doc. So we've got the medical piece, we have the therapy piece, we still have those licensed clinical social workers who are embedded in the practice to be able to provide therapy for our patients. And then now we're in the process of adding on additional support in the way of social workers who aren't necessarily clinical social workers. They're not providing cognitive behavioral therapy, but they're there to address other needs of these patients. And so things like social determinants of health that are maybe contributing to their behavioral health issues or their mental health issues. So things like housing insecurity, food insecurity. We have embedded social workers that are able to address some of these issues, transportation issues, to getting to appointments, so that we're better able to meet the needs, the mental health needs, behavioral health needs of our patients. And then finally, when we're looking at what our model is, we also have an arm of medication-assisted treatment. We call that MAT for short, and that is for patients who have a history of opioid dependency. We are able to get them onto medication that we're able to get them off of their illicit substance and get them onto to therapy, things like Suboxone, where we're able to manage their opioid addiction. And again, we do that from an embedded standpoint. We have a doc in a primary care practice who is able to meet those needs for those patients with opioid dependency.